Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
The widespread use of pneumococcal conjugate vaccine in children has significantly reduced the incidence of pneumococcal disease through direct and indirect effects. However, pneumococcal pneumonia still accounts for over 200,000 adult hospitalizations in the U.S. each year. Higher rates of pneumococcal disease are observed in older adults, those with underlying conditions, and certain racial groups. Joining me today to discuss the newest pneumococcal vaccine, PCV21, and the recent expansion of age-based pneumococcal vaccine recommendations is my Vizient colleague, Dr. John Schoen, Senior Clinical Manager of Drug Information at the Vizient Center for Pharmacy Practice Excellence. I am Stacy Lauderdale, Associate Vice President at the Vizient Center for Pharmacy Practice Excellence and your program host. Welcome back to the podcast, John.
I appreciate it. Thanks for having me back.
John, this is the third time you've been on Verified RX to talk about pneumococcal vaccines because there's been a lot of changes. You recorded your first pneumococcal vaccine podcast in March 2022, and then your second podcast in February of 2024. We'll put the links to those podcasts in the show notes if anybody wants to review. There has been additional changes in the pneumococcal space since you last appeared on Verified RX for pneumococcal vaccines. Let's walk through each of those changes separately. There's been a brand new pneumococcal vaccine product approved. Why don't you tell me a little bit about that?
There was a new vaccine that was approved in June of last year. It's a 21-valent pneumococcal conjugate vaccine, or PCV21. Brand name is Capvaxive. It's a product from Merck, who also has a couple other products that are on the market, including PCV15 or Vaxneuvance, as well as PPSV23, which is Pneumovax. Specifically, this new product, the PCV21, was approved for adults 18 years of age and older only for the prevention of both pneumonia as well as invasive pneumococcal disease. Invasive pneumococcal disease includes the infection of sites that are normally sterile, things such as meningitis, septic arthritis, osteomyelitis, pneumonia with bacteremia, as well as bacteremia without a focus of infection. For the pneumonia-specific indication, that was approved under an accelerated approval pathway, and we're waiting on results of a confirmatory trial with more data around that. What I do want to point out with this vaccine is while it has 21 different serotypes that it covers, it is not just PCV20 plus one serotype. It's quite a bit different than the Pfizer PCV20 or Prevnar 20 product. It actually includes 11 distinct serotypes compared with PCV20.
I want to expand on that a little bit more. In preparation for this podcast, I was reading that invasive pneumococcal disease can be caused by 90 different serotypes. We have PCV15, PCV20, and PCV21 now, at least for adults. Let's focus on the difference between 20 and 21 because you told me there's 11 different serotypes. Does that difference matter?
Do we have data to show that PCV21 improves clinical outcomes compared with PCV20? The answer is no. We don't have that data. And we really don't have data for any of the newer pneumococcal conjugate vaccines around clinical outcomes, such as the invasive disease or pneumonia due to the Streptococcus pneumoniae. But what we do have are the immunogenicity studies. So we know what these vaccines are effective at in terms of producing immune responses to the serotypes that are included in those vaccines. What we can do is look at the rates of invasive pneumococcal disease in the United States and look at which of those serotypes are most commonly causing those infections in the adults. PCV21 covers 11 unique serotypes that are not covered in PCV20, and those serotypes currently account for approximately 37% of invasive pneumococcal disease in adults, and that's based on data from 2018 to 2022. Conversely, while you are covering 11 unique serotypes with PCV21, you are giving up some serotype coverage that PCV20 has. And those serotypes where PCV20 covers, but PCV21 does not, accounts for approximately 10% of invasive pneumococcal disease in adults. There is a little bit of a trade-off, but ultimately your broadest coverage is with that PCV21 vaccine. That being said, there is some variance within geographic locations as to which serotypes are more prevalent. One of the notable serotypes that is not covered in PCV21 that is covered in PCV20 as well as PCV15 plus PPSV23 combo is serotype 4. Certain geographic locations in the United States, up to and exceeding 30% of the invasive pneumococcal disease in those populations is caused by serotype 4. These geographic locations include Alaska, Colorado, New Mexico, Oregon, and the Navajo Nation. Generally, the risk factors in those populations where we see that serotype 4 invasive disease are in patients that are under the age of 65, but they have some kind of underlying condition such as chronic lung disease, smoking, and injection drug use, or alcoholism. In terms of which of these vaccines provides the broadest coverage, it depends on what the serotype distribution looks like in your geographic location. In the areas that I just mentioned, PCV20 or a combination of the PCV15 with PPSV23 might provide broader coverage in those populations, whereas if you look at other areas such as the Midwest, Eastern, and Southern regions of the United States where you don't really see a significant percentage of serotype 4 represented in that invasive disease, PCV21 might provide you broader coverage. Ultimately, to say one is better than the other, we don't really have the data on what the clinical outcomes are, and ACIP does not have a preference of using one versus the other.
Let's get into that. One of the things I'm hearing now is that PCV21 is better than PCV20. If you go up onto Merck's website, they definitely list that it provides broader coverage. 83% of serotypes for PCV21 versus in the 50th range for PCV20. Walk me through why one is not better than the other and why I shouldn't, from a formulary standpoint, prefer PCV21.
If you are looking at right now, what are the most common serotypes that are causing invasive pneumococcal disease? Broadly speaking, PCV21 does provide broader coverage, but there is geographic variability. You can't say across the board that PCV21 is always going to provide the broadest coverage. The other thing to consider is PCV21 has gaps in coverage for serotypes that used to be and still are included in some of these other vaccines. And those serotypes were presumably selected for a reason. At the time those vaccines were being developed, they were probably some of the serotypes that were more commonly associated with the invasive pneumococcal disease. One of the long-term things that PCV21 is relying on is for those serotypes that are not covered in PCV21 to be covered and have some sort of degree of herd immunity from the pediatric immunization series. There is precedent for that. If you look at PCV13, for example, in its herd immunity for adults over 65, when it was introduced for pediatric immunization series, there was the study showing a 60% reduction in invasive pneumococcal disease in that older population just based on the immunization of that younger population. But that relies on the pediatric immunization uptake being good for covering those additional serotypes. Ultimately, I can't really say as far as clinical outcomes go, and I don't necessarily think there's a right or wrong reason to say like you'd be wrong to use PCV20 if you lived in the South. The important thing is making sure that people who are at risk and are recommended to get these vaccines are getting a recommended pneumococcal vaccine. ACIP doesn't recommend one or the other.
That's very well stated. Key takeaway, one is not preferred right now, although PCV21 does have at least broader coverage.
Yes.
Let's shift gears and talk about another new recommendation. ACIP met in October, and they made a new recommendation for pneumococcal vaccines. And that recommendation was that they lowered the age for universal pneumococcal vaccination from age 65 and older to 50 years of age and older. When I think about the vaccine landscape coming out of the pandemic, there's been increased vaccine hesitancy. It's important that we understand what was that recommendation based on so that we can better inform our patients.
Yep. The new recommendation is lowering that age of universal pneumococcal vaccination from 65 to 50. When ACIP met in October last year, there were really four main considerations they discussed related to this change in their recommendation. The first one is around health equity. It was felt that the updated expanded age-based recommendation is expected to improve pneumococcal disease prevention in adults in that 50 to 64 year age range, particularly among the demographic groups experiencing higher disease rates. The other consideration is looking at the prevalence of a risk-based indication in that age group between 50 and 64. Roughly about 32 to 54% of adults in that age group already have a risk-based indication, but there's a disparity when you look at vaccine uptake for those adults that would have been recommended to get a vaccine based on risk factors compared with what that vaccine uptake looks like based on an age-based recommendation, which was previously 65 and up. So when you look at adults that are 50 to 64 with a risk-based recommendation, only about 37% of the adults in that group have received a pneumococcal vaccine compared with 70% of adults 65 and older based on that age-based recommendation. The thought is lowering that down up to half potentially of the adults in that category would already been indicated anyway. So you're just going to be increasing the coverage of those adults that should be and would be recommended to be getting this vaccine. Additionally, simplicity with a uniform recommendation was certainly a consideration. There's been a trend in recent years in shifting away from some of those shared clinical decision-making recommendations that just introduces some complexity in terms of navigating the vaccines and having those conversations. So just a more simplified recommendation was something that they looked at. And then finally, they also looked at data from some economic modeling studies. They had a couple different models they looked at and some different strategies. One was a moving strategy, which is essentially what the recommendation we have looks like now and going from 65 to 50. They also looked at an adding strategy of basically keeping that 65 and up and then including a 50 and up as well. And as far as the moving strategy goes, that was cost saving across the board in the model, with the lower cost effectiveness ratios consistently being with PCV21 versus PCV20. There are certainly limitations in those models that need to be taken into consideration, such as uncertainty around the duration of protection from the pneumococcal conjugate vaccines. We still don't have a definitive answer on how long these vaccines provide coverage, as well as the magnitude of indirect effects, such as pediatric vaccination, as well as impact of potential future supplementary pneumococcal vaccine doses in adults.
One of the things that I read preparing for this podcast was the January MMWR, and we'll put the link to that in the show notes as well. The MMRW states among adults aged 50 to 64 years with invasive pneumococcal disease and those hospitalized with pneumococcal pneumonia, approximately 90% had one or more risk conditions. If I'm a healthy 50-year-old who has no risk factors for invasive pneumococcal disease, why should I get a pneumococcal vaccination?
One thing that I want to address before I dive into what the risks look like in that population is the question of, if you're 50 and older, does everyone 50 and older need a vaccine? It's important to remember that the recommendation is for pneumococcal conjugate vaccine naive patients. Just because you're 50 and older now, you don't need to get another vaccine if you received one of those others. So not necessarily everyone over 50. But when you look at healthy adults, presumably they're not in that bucket where they've received it previously. And so the question is, if they're healthy, have no other risk conditions, do they need the vaccine? This really emphasizes the increased focus on trying to improve vaccine confidence. And while this is just a flat age-based recommendation, I don't think that means there's no discussion needed or anything like that with the patient. There's still definitely importance of having that informed decision-making process with the patient so that they can understand the risks versus benefits and make that decision for themselves. When you look at risk versus benefits from a safety standpoint in terms of adverse effects and serious adverse effects, the pneumococcal vaccines are generally very well tolerated. So there's not a ton of safety concerns. From a risk standpoint, not a huge factor here. But then in terms of trying to describe what are the benefits for this population, one of the challenges is the studies that we have that approve these newer vaccines are really just looking at immunogenicity. We still don't have data to be able to put a number to and say, for this age group, you can expect this degree of reduction in risk of pneumonia or invasive disease or anything like that. The closest thing that we really have is around some of the data with PCV13 in adults 65 and older. There was a large trial called the Capita trial, and that study showed for PCV13, there was a 45% reduction in pneumonia and a 75% reduction in invasive pneumococcal disease. But that's PCV13 in an older population. We don't really have the data to say, what does that look like in 50 to 64? With that being said, the next thing that you can really consider is looking at what does the risk look like, or how much additional or less risk do you have if you're 50 to 64 and you don't have one of those additional risk factors. Having one of those risk factors, and this does not include immunocompromised states, your risk goes up more significantly if you are immunocompromised, but just one of those general chronic medical conditions that would place you at increased risk. You have a 3 times higher risk of pneumonia and over 4 times greater risk of invasive pneumococcal disease if you just have one or more of those risk factors if you're in that 50 to 64 group compared with those who are otherwise healthy. The other thing to keep in mind is age in and of itself is a risk factor for pneumococcal disease. So as you get older, your risk goes up of pneumococcal disease. One thing that you can look at for a frame of reference is healthy adults in that 50 to 64 age group. What does their risk look like compared to a younger adult population? Compared to adults less than 50, their risk of pneumonia is about 1.5 times higher, and their risk of invasive disease is about 3 times higher compared to adults less than 50. If you look at the older adult population, 65 and up, the risk in that 50 to 64-year-old population is lower. So about 2 times lower than those 65 and up for risk of pneumonia, and about 2.5 times lower for invasive disease compared with adults 65 and older. And the reason that I bring that point up is because there is a little bit of uncertainty around the duration of protection that these pneumococcal conjugate vaccines provide. in terms of when we can actually expect the waning to occur in terms of protection. And if you look at economic modeling studies, they generally use around 15 to 20 years in their assumptions. Whether that's right or not, I don't think we know. But just for the sake of an example, say that it is 15 years where the vaccine efficacy starts to wear off. And you have a patient that was completely otherwise healthy, age 50, got pneumococcal vaccine. 15 years later, they're 65. Their risk is now higher. But if they don't get any other pneumococcal vaccines and that starts to wane off, you have less protection at a point in life where your risk is actually higher. That's all just for sake of example and just thinking through this in that decision process. Ultimately, I wouldn't place a lot of weight in that because with all the change that's coming down the pipeline with pneumococcal vaccines and the changes with recommendations, I highly doubt the vaccines and the recommendations that we have today are going to be the same 15 years from now. Just having that conversation with your healthcare provider, assessing your own risks, what's your risk tolerance with these vaccines, and then making that decision. Purely from an ACIP standpoint, everyone over 50 would be recommended to get a pneumococcal vaccine.
Thanks, John. I think that was a difficult question, but agreed that having that informed discussion between patient and physician is probably the most important for increasing vaccine confidence. A point you made earlier, which is we still have very low coverage among those patients that are at an increased risk between the ages of 50 to 64. So making sure that you certainly have that discussion to increase those coverage rates.
Absolutely.
Shifting gears once again, I know, and I'm going to let you educate me because I didn't look at detail, but I know there's been some additional changes to the pneumococcal vaccine schedule. I'm hoping that it's been clarified a bit because the feedback I heard the last time was how complicated the pneumococcal vaccine schedule had gotten for practitioners on the front lines. Can you summarize some of those changes that have additionally occurred in this most recent iteration?
The main other change to really highlight that was provided in the MMWR in January is the removal of PPSV23 or Pneumovax as an option in most scenarios with a preference for PCV20 or PCV21 instead. We are moving in a direction that's more simplified. I don't think we're quite at a state where I would call these recommendations simple yet, but we are moving in a direction that is a little more simplified. Essentially, what this change does is when you are looking at the previous pneumococcal vaccine history of patients, there were a number of scenarios where, depending on what they got, they could have received one of the newer pneumococcal conjugate vaccines or PPSV23. For example, patients who have only received PCV13 in the past but have not completed their series would have previously been able to complete that with PCV21, PCV20, or PPSV23. Now with this new recommendation, PPSV23 is no longer recommended. In that scenario, it would be recommended to just give either PCV20 or PCV21 to complete the series. Ultimately, what this all means in adults is that basically the only time that PPSV23 is really recommended anymore is in patients that get that PCV15 vaccine, because that is how that vaccine is indicated to be given in that series sequentially with PCV15 followed by PPSV23 a year later.
All right, that's a little bit easier. Clarifies it a little bit. One of the points that I've heard is at the point of care, it's like, which one do we give? But good to know that it's being streamlined a little bit. All right, so one of the things that I've heard lately is about this concept around vaccine stewardship, that there's a lot of opportunities around ensuring that your outpatient formulary from a vaccine standpoint makes sense. What should organizations consider when selecting a vaccine and in specific regards to pneumococcal vaccines?
There's a number of things that they could potentially consider. One is looking at the approved populations for the vaccines as well as what their specific population looks like. Certainly, there are some differences in serotype distribution for the invasive pneumococcal disease based on geographic location. The other thing to consider is just what types of patients are you seeing? Are you seeing all adults? Or are you seeing all pediatric patients? Are you seeing a mix? Because not all these vaccines, like PCV21, for example, is not indicated for use under the age of 18. The other thing in terms of general considerations around inventory, ordering and stocking multiple vaccine products, the more vaccine products that you stock, you increase your chance of a potential med error, such as situations where you give an adult vaccine accidentally to a pediatric patient, which might be a risk with PCV21 currently. And then, of course, just contracting opportunities and aligning around certain manufacturers. Sometimes vaccine contracts do that. If you're trying to align around Merck, then PCV15, PCV21, PPSV23 would be your products of choice. And if you're aligning around a contract involving Pfizer, then you'd be looking at PCV20.
So dare I ask, the pneumococcal vaccine landscape has changed in the past couple of years. Is there anything that we expect in the immediate pipeline that would further make contracting and selection of these vaccines more complicated?
One thing to consider with PCV21, to my knowledge, Merck is not pursuing the use of that vaccine for a primary pediatric immunization series that would be less than 2 years of age. The plans are to keep PCV15 for that patient population. If you were planning on using PCV21 as your only vaccine that you stock, I don't think that's really an option. It's definitely not an option right now because it's only approved for 18 and older. It's not going to be an option down the road either because it's not going to cover the pediatric immunization series. You may see expansion of PCV21 to include the age range of 2 to 17. There is an ongoing study with PCV21 in that population that has risk factors. So it could potentially see expansion there. But as far as primary immunization series, I don't think that is in the plans for PCV21. There are other pneumococcal vaccines coming down the pipeline. I don't think that this is going to be something that we're going to see in the near term. Most of these are in phase 2 studies right now, but we do have another PCV21 vaccine from Sanofi that is in the pipeline. This is quite a bit different than the PCV21 that we've been talking about today. This is actually basically PCV20, Prevnar 20 plus one additional serotype. So a different strategy for that 21 valent vaccine. There's also a couple 24-valent vaccines in the pipeline, one from GlaxoSmithKline and another one from Vaxcyte, again in phase 2 studies. And then finally, there's a 31-valent PCV vaccine from Vaxcyte that is supposed to be getting phase 2 studies in the first quarter of this year. More changes coming, but I don't think that there's going to be any in the near term anyway.
So it'll be a decision between Merck and Pfizer, at least in the near term. Well, we appreciate you joining us today, John, to go over the details and clarify the newest MMWR. I know you also recently updated a side-by-side on pneumococcal vaccines, and we'll go ahead and drop the link in the show notes as well.
Yeah, great. Thanks for having me.